The Western Elbow Positioner is a simple device that was designed to maximize the access to the operative site during arthroscopic or open elbow procedures. It is a low-profile device designed to eliminate interference during surgery. The support bar is held in a Clark clamp on the OR table. It is fully adjustable in two planes, which allows simple arm placement. The offset bar provides optimum room around the elbow for instrument and scope placement. The Bicep Pad allows tilt and rotation so that the device can secure the arm but prevent pressure points by fitting with the arm. The bicep strap secures the patient's arm to the bicep pad. Height is fully adjustable by changing its vertical position in a Clark clamp. The patient can be positioned in either the lateral decubitus or prone positions. For lateral positioning, the patient is intubated and placed in the lateral decubitus position. A Clark clamp is put on the rail on the operative side of the OR table. It should be positioned either 6 inches proximal or distal to the shoulder. The position should be determined by the surgeon. A tourniquet is placed on the patient's operative arm over the bicep. The Western Elbow Positioner is placed into the Clark clamp and adjusted to a height so the shoulder will be positioned in 90 degrees of abduction and the elbow is flexed 90 degrees over the Western Elbow Positioner pad. The bicep pad should not be directly under sensitive nervous or vascular structures at either the elbow or shoulder. The support bar is adjusted so that the bar is positioned close to the patient's chest, but not touching the chest. The rotation and tilt of the bicep pad is then locked and the bicep strap is tightened in place. Do not over-tighten. The hand, wrist and arm are prepped up to the bicep pad. Then the arm is draped so that the elbow and distal part of the upper arm are in the sterile field. If the procedure is done in the prone position, the lower half of the support bar is removed by unscrewing the lower knob. The upper half of the Western Positioner is then inserted into the Clark clamp, and the remainder of the procedure is the same as for the lateral position. The patient's limb is placed on the Western Positioner and strapped into place. All of the adjustments are made so that the bicep pad is not directly under sensitive nervous or vascular structures at either the elbow or shoulder. The patient is then draped so they are ready for the procedure.
Well, we developed the Western Elbow Positioner because of a problem in positioning the arm when the patient's in the lateral decubitus position. In this situation, the current elbow positioners often caused a lot of pressure in the antecubital fossa, preventing us from gaining access to the elbow, particularly when we're doing arthroscopic surgery of the elbow. But it's also true when you're fixing fractures about the elbow, including the distal humerus and proximal ulna. So we found the development of the Western Elbow Positioners allowed us to more securely position patients intraoperatively so that the arm's not shifting around during the surgery, and it's also allowed us to do surgical procedures, particularly arthroscopically, that we couldn't do before. Many of the currently marketed positioners tend to cause pressure in the antecubital fossa because the bolster tends to ride down in the antecubital fossa, and if you're doing that and you're trying to do an elbow arthroscopy, you're simply going to fail. Furthermore, it allows a very reproducible position of the patient, which can be maintained throughout prolonged operations in some situations.